It is 2:14 a.m. and you are signing a piece of paper that will take away someone's freedom. The patient is a 31-year-old woman brought in by police. She hasn't slept in 6 days. She believes she is receiving messages from the emergency broadcast system. She tried to walk onto the freeway an hour ago. She is looking at you. She says very clearly, "I know my rights." You sign the form, 72-hour involuntary hold, your name, your license number, your clinical justification. She will be taken to a locked unit. The door will close behind her. She cannot leave. In every other branch of medicine, the doctor treats the body. In psychiatry, the doctor can also decide that your mind is broken enough to override your will. No other physician in any hospital has this authority. You will spend the next 30 years learning what to do with it. Level 1. The locked ward. You are 24 years old, halfway through medical school, and you have just rotated off surgery. Surgery made sense. A problem you can see, cut, fix, close, vital signs on a monitor, outcomes you can measure. Psychiatry is the next 4 weeks. The attending meets you in the lobby and walks you to a door you haven't seen on any other rotation. Heavy frame, electronic keypad, the attending badges in, and it clicks open. On the other side, a hallway that looks almost like a regular hospital floor. Almost. No sharps containers, no IV poles, plastic silverware. Patients in socks with rubber grips. No laces. The windows don't open. A man in his 50s watching television hasn't spoken in 3 days. A 19-year-old drawing with crayons, wrists bandaged. Another patient pacing the hallway, talking to someone who isn't there. The tools on this unit are a conversation, a prescription pad, and a locked door. Your first day, the attending pulls a chair up to a patient's bedside and talks for 45 minutes. No instruments, no imaging. Just questions about childhood, sleep, relationships, voices. On surgery, the attending spoke to the patient for 4 minutes. The clerkship lasts 4 weeks. During that time, one moment stays. A patient, a 42-year-old teacher who has been on the unit for 8 days, asks if she can talk to you. Not the attending. You. She talks for 20 minutes about a feeling she can't name, about the morning she couldn't get out of her car in the school parking lot and sat there for 2 hours with the engine running, about the part she doesn't understand, that she has a family, a job, a reason to be alive, and none of it is enough. You don't fix anything. You sit there and listen, and at the end, she says, "Thank you. Nobody has asked me about any of this." You walk out and don't say anything to anyone for the rest of the day. Match day comes in March of your 4th year. The match is not competitive. 2,388 spots. The interview matters more than the board scores. Can you sit with someone in distress without trying to fix it? You match. An attending in surgery says, "You're smart. Why psychiatry?" You'll hear this for the rest of your career. You never come up with a good answer because the question was never really a question. Level 2. The resident. Intern year is not psychiatry. Most programs start you on internal medicine wards. You are managing heart failure, diabetic ketoacidosis, sepsis. 80 hours a week, overnight call, 20 patients. The medicine teams know you're headed to psychiatry. Sometimes this matters. A senior resident introduces you to the team as our future psychiatrist, and you can hear the quotation marks. The purpose. Later, when someone on a locked psychiatric unit develops chest pain, you need to know whether it's anxiety or a pulmonary embolism. PGY2. The psychiatry begins. You badge through the locked door. This time it's your unit. 12 patients. Morning rounds start at 8. Each one gets a chart review, a mental status exam, a medication check, a safety assessment. A mental status exam is not a physical exam. You are watching how someone speaks, the speed, the volume, whether thoughts connect or scatter, hallucinations, delusions, plans to harm themselves or others. You document all of it, every session, every patient. Week 3. The attending hands you a form and says it's time. A patient has been brought to the emergency department by his roommate. He has a plan, he has the means, he will not agree to voluntary admission. You ask the question, the one no other doctor in the hospital is trained to ask this directly. Do you want to die? He says yes. You fill out the involuntary hold, your signature, 72 hours. He looks at you with something between rage and relief, and you can't tell which is real. The door closes. That night, you sit in the call room. You overrode someone's stated wishes, a structured interview, a clinical framework, and your own judgment as a second-year resident. That was the basis. You believed he would kill himself if you didn't sign. You were probably right. You will never know for certain. The psych ER at night is its own world. 2 a.m. An agitated man brought in by police in handcuffs, speaking in a language nobody on the team recognizes. An overdose. 17-year-old conscious, not making eye contact. A woman in her 60s brought by her daughter, who says her mother has been talking to her dead husband for 2 weeks and won't eat. Some nights you order chemical restraints, haloperidol and lorazepam, intramuscular, a patient who has become physically dangerous. You document the justification. You check on them every 15 minutes. This is care, and it is also force, and you don't always know where the line is. Psychiatric patients board in the ER for days sometimes, waiting for an inpatient bed that doesn't exist. You are managing crisis-level illness in a hallway. The system runs on shortage. Third year, you rotate through the subspecialties. Consultation liaison, embedded in the general hospital. A cardiologist pages you. Patient on my floor refusing dialysis. Is she competent to make that decision? You go to the bedside and spend an hour determining whether a person has the right to die on her own terms. You write a note. The medical team reads it. Your opinion becomes the institutional answer. Forensic, a county jail. You're buzzed through 4 locked doors. The defendant sits across from you in an orange jumpsuit. He's been charged with assault. You're here to evaluate whether he understands the charges, the role of the jury, whether he can assist his attorney. He tells you what happened. You write it down. 3 weeks later, you testify. 4th year, the patient's suicide. 32 to 61% of psychiatry residents lose a patient to suicide before they finish training. Half of them face it in the 1st or 2nd year. Yours is a 48-year-old man you discharged 9 days ago. He seemed stable. The medication was working. He had a follow-up scheduled for next Thursday. His wife calls the clinic. She is not screaming. She is very quiet. You sit in the workroom afterward. There is no debrief, not a real one. A peer support number on a laminated card by the phone. You think about every decision. The discharge, the follow-up interval, 9 days. You know from the literature that psychiatrists cannot reliably predict individual suicides. The tools work on populations, not on one person in a room. Knowing this does not help. You have clinic tomorrow. Level 3, the fork. Residency ends on a Friday. By Monday, you have 4 job offers and a decision that will shape which patients you see for the next 30 years. Community mental health, $220,000. A clinic with a metal detector in the lobby and a 4-month wait list. 600 patients with schizophrenia, bipolar 1, severe PTSD. The patients nobody else will see. The lowest salary in psychiatry. Insurance-based private practice, $300,000 to $400,000. 22 patients a day, 15 minutes each. 40 minutes on the phone to get prior authorization for a drug that costs $11. Cash only, $450,000 to $690,000. 5 patients a day, 45 minutes each, $400 to $600 per session. The medicine you practice here is closer to what drew you to the field. The patients who need it most can't afford your door. Academic medicine, $220,000 to $280,000. The lowest pay, the longest hours, and the only path that leads to the top. Most pick insurance. You pick insurance? Your first week as an attending, a woman waits 8 weeks for the appointment. She sits down and tells you about the past 3 years, the job she lost, the marriage that ended, the morning she locked her bathroom door and held a bottle of pills and put them back. She's been waiting 2 months to tell someone. You listen for 40 minutes and prescribe in the last 5. She cries. The next patient is already in the waiting room. By year 2, you recognize the revolving door. A patient you admitted to the inpatient unit 2 months ago is back in the ER. Same psychosis, same lack of housing, Same missed follow-up because the community clinic had a 4-month wait. You stabilize her again. The locked unit holds her for 5 days, the door opens, and she walks back into nothing. 73 to 78% of psychiatrists meet validated burnout criteria, higher than orthopedic surgery, higher than emergency medicine. The last patient of the day is in the waiting room. You have 12 minutes. Level 4, the escape. 5 years into insurance practice, you take the academic job you turned down after residency. The pay drops by a third, the schedule gets longer, but you are no longer spending 40 minutes on prior authorizations for a drug that costs $11. Some of your co-residents made a different exit, dropped insurance entirely, $500 a session, 5 patients a day. 122 million Americans live in mental health shortage areas. The cash-only psychiatrist sees none of them. You went the other direction. You have an NIMH grant. You run clinical trials. The question you are chasing: why do some brains respond to treatment and others don't? The ECT suite is behind a locked door on the 3rd floor. You're in there 3 mornings a week. Electroconvulsive therapy, the most effective treatment in psychiatry. No other treatment in the field comes close. The patient is under general anesthesia. You place electrodes on the skull. You press a button. An electrical stimulus lasting less than 8 seconds. On the arm without the muscle relaxant, the toes twitch rhythmically for 30 to 60 seconds. A controlled seizure. The patient wakes up confused. They don't remember coming in. They don't remember much of the past few weeks. That is the price. Memory loss, sometimes temporary, sometimes lasting. The most effective treatment in psychiatry, and it takes something from you. 3 times a week, 8 to 12 sessions, and the depression that made them unable to eat or speak or stand begins to lift. One of your outpatients followed you from the insurance practice. 3 years you've been asking her. Every week in the outpatient clinic, the same question: do you want to die? Every week, the same answer. After the 8th session, you ask again. She takes a while. She says she isn't sure. That is what ECT gives most of the time. Not certainty, just doubt where there used to be none. The other frontier is ketamine. Esketamine nasal spray got FDA approval in 2019, the first new mechanism for depression in 60 years. A full infusion. A 36-year-old who has failed 4 medications sits in a reclining chair. You start the drip. Over 40 minutes, dissociation, a floating feeling, visual distortion, altered time. Some patients describe it as the first relief they've felt in years. The effect begins within hours, not weeks. Over 1,000 private ketamine clinics now operate across the country, some run by psychiatrists, some by anesthesiologists with weekend certifications. The regulation is minimal. The price is $400 to $800 a session out of pocket. The treatments that work the best reach the fewest people. Someone above you decides which treatments count and which suffering gets a name. Level 5, the chair. You run the Department of Psychiatry at a major academic medical center. This is the smallest and most underfunded department in most hospitals. The operating room generates revenue. The cardiac cath lab generates revenue. The psychiatric unit generates litigation. Monday is budget meetings. 2 new attending lines, denied. The emergency department director wants to discuss psychiatric boarding times, which have tripled in 5 years. You advocate for beds that don't exist and funding that doesn't come. 30 years in, you have carried a specific weight. You have lost patients, not 2 or 3. Over a full career in psychiatry, the number of patients who die by suicide is a number you know exactly and do not say out loud. You read Kay Redfield Jamison's memoir in residency. She has bipolar disorder, attempted suicide during her training while studying the same illness she was living with. She disclosed this publicly in 1995. The stigma didn't disappear. She cracked it open. Viktor Frankl's book was on your med school reading list. He survived Auschwitz. His wife, parents, and brother did not. He came back and built a therapeutic framework around one idea, that meaning can survive inside suffering. 16 million copies. The field you lead has also done extraordinary harm. Walter Freeman performed 3,500 lobotomies, driving city to city in what colleagues called the lobotomobile, an ice pick above the eyeball hammered in with a mallet. Rosemary Kennedy was 23. Her father ordered the procedure without telling her mother. She was institutionalized for the rest of her life. Mainstream psychiatry endorsed it for 2 decades. In 1952, the DSM listed homosexuality as a mental disorder. 21 years. A generation of gay Americans diagnosed, institutionalized, subjected to electric shocks and nausea-inducing drugs. The same profession that now calls itself the guardian of mental health. Removed by vote in 1973. The margin was 12 points. Every generation of psychiatrists believed they were doing their best. You now sit on a DSM work group. The 6th edition is in development. You are one of 160 experts. The question in front of you is not whether the patient in the ER is psychotic. You answered that question decades ago. The question now is larger. What counts as a disorder? If your work group adds a diagnosis, insurance companies must cover it, schools must accommodate it, pharmaceutical companies can develop drugs for it. Millions of people who had no name for what they were feeling now have one. If you raise the threshold, some of those people lose coverage. If you lower it, the field gets accused of medicalizing ordinary life. The locked ward where you first badged in as a student, someone in a room like this one decided who belonged there. Somewhere, a 24-year-old medical student is walking onto a locked psychiatric unit for the first time. The door is heavy, the keypad beeps, the attending badges her in. On the other side, a man who hasn't spoken in 3 days. A teenager with bandaged wrists, a woman pacing the hallway, speaking to a voice only she can hear. There are no monitors, no scalpels, no imaging suite down the hall. The student will sit at a bedside this week and ask a stranger about the worst thing that has ever happened to them. She will learn to ask, "Do you want to die?" without flinching. She will sign her first involuntary hold before she turns 30. She will lose a patient. She will prescribe a medication that doesn't work, and then one that does, and she will not fully understand why. She doesn't know any of this yet. She doesn't know where the locked door started. A committee room, a diagnostic code, a vote that passed by 12 points. The door clicks shut behind her.